From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews. Thank you for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. And today we're going to look at nicotinamide supplementation and primary open-angle glaucoma in patients with ocular hypertension. This cohort study used data from 67 U.S. healthcare organizations between March 2006 and March 2026. Joining me to discuss this publication is the corresponding author for that investigation, Dr. Ahmed. Dr. Ahmed is with the John A. Moran Eye Center at the University of Utah in Salt Lake City, Utah. Ike, thank you so much for joining us.
Neil, thank you so much for having us here. We're thrilled to be with you here and part of JAMA Ophthalmology. Thank you so much.
Also joining me is first author of this publication, Dr. Jawad Muayad. Dr. Muayad is at the Bernice and Harvey Jones Eye Institute of the University of Arkansas for Medical Sciences in Little Rock, Arkansas. Jawad, thank you also for joining this podcast today.
Thank you so much for having me. It's an absolute pleasure.
Ike, maybe I could start with you. Could you walk us through, was there any biologic rationale that somebody might want to consider nicotinamide supplementation to possibly be a neuroprotective agent, not an ocular antihypertensive agent, but a neuroprotective agent? What did you know about it before you got into this investigation?
Well, thanks, Neil. You know, we know more and more over the years that glaucoma is really a metabolic neurodegenerative disease of the retinal ganglion cell. And of course, IOP being one of the main risk factors. And we're all in search of a non-IOP related neuroprotective agent. Nicotinamide came on the scene a number of years ago. In fact, there was a seminal publication in JAMA Ophthalmology 2021 by one of our co-authors, Gus Demorius, in a phase 2 trial showing visual field improvement and preservation in a short-term study with patients who took this agent versus those that don't. Now, there is reasonable preclinical research to support the mechanism of action of nicotinamide. We know over age, over time, retinal NAD plus falls. And these neurons are more vulnerable to the energy crisis that happens under the stress of IOP. Nicotinamide is a direct precursor of NAD+ and replenishes. It also inhibits PRP1, which is an enzyme that burns through NAD+ through oxidative stress. So there's a preclinical mechanism for which nicotinamide may have a beneficial function on the mitochondrial function in RGCs. So basically, that's the preclinical biological basis for it. There's a lot of research being done. And on a personal level, I routinely now see patients in my clinic asking me, is there anything I can do beyond just lowering pressure to help preserve my vision? And so we know the research being done in this area. And so it was a very clinical question, a very patient-facing question we wanted to try to address. And what better way than to have big data? And that's where Jawad and I have a lot of experience working with federated databases like TriNetX, and we felt this would be a good study to look at in early glaucoma.
So Jawad, let me turn to you. That's a good introduction to why look at nicotinamide. Was this the only supplement that you looked at for trying to see if you could prevent the onset or maybe early deterioration of glaucoma? Or did you look at a group of them? And this is the report on the nicotinamide investigation.
Yeah, so this really was the only one we looked at. Just like Dr. Ahmed said, the literature backing this supplement in this specific scenario looking at glaucoma is well-founded. The American Academy of Ophthalmology recently released a report looking at nicotinamide and glaucoma. But when you look at sort of how does it work real world, the data has been limited. And so that's sort of the question that we wanted to ask ourselves is, if we see this in preclinical trials, if we see this in basic animal science models, does it reflect real world? Does it reflect in a more pragmatic approach? And so that was sort of the goal of this study.
And I know that TriNetX is not a population-based cohort, but could you give me a little idea of who's in this cohort? Is this just one region of the United States? Is it many areas throughout the world? Who are these people we're going to look at to say, did you have nicotinamide supplementation or not?
So these are the patients that you see in clinic every day. TriNetX, you can even look at it globally. So we can select which sort of regions we're looking at. And one of the options is to look at the entire globe. But the issue when looking at that is that coding changes per region. And so we focus on the United States in particular. Like you said, it covers 67 healthcare organizations that are all across the United States. And just like as I said before, these are the patients that you see. These are the patients that are in your electronic health record, where you input your codes, where you input what treatments you gave them, what diagnosis you're coding them with. These are the patients that you're seeing every day, that it's much more part of routine practice.
So, Ike, let me ask you, I always wonder about some of these database reviews when they look at, for example, over-the-counter supplementation. I understand nicotinamide is, at least for all intents and purposes in this study, being considered as an over-the-counter supplementation. Do you routinely, at least now or in the last few years, ask your patients if they have this? That doesn't mean everybody else does, but just as a glaucoma expert, is that something you're now collecting from them on sort of their intake information?
Yeah, it's a good question. I mean, whether it's glaucoma or cataract or anything else, I mean, we know some of these over-the-counter remedies have impact on disease. And so I think it's an important thing to do. We do this especially with nicotinamide, with the evidence around that. We have people taking acetylcholine from Europe, people taking other extracts, ginkgo, all these other over-the-counter supplements, which is very common, particularly in patients with glaucoma with more advanced disease, where patients are progressing despite pressures that would be otherwise reasonably felt to be controlled. So yeah, it is something I think that is more relevant. It also leads to one of the limitations of our study, in that the exposure to nicotinamide often being over the counter. So as Jawad said, this is a EHR database. And so basically, unless it's actually documented in there, it wouldn't be actually counted in this particular study. But if anything, that misclassification biases toward the null, right? Because basically the effect could even be stronger because it undercounts who's actually taking it. So, but it is something that obviously we had enough data to support and to actually analyze, where it was documented and was prescribed, and therefore we were able to actually look at that comparison.
And one point to add to that is the EHR is linked to whether they've seen their eye care provider or they see their primary care provider. And so let's say they go see their primary care physician and they record all the medications and supplements that they're on. That's recorded even when they go see the ophthalmologist. So we're kind of aggregating this data across their entire record as well.
So Jawad, let me come back to you then, and let's talk about the two groups that you're comparing. You have a group of people that are documented as having nicotinamide somewhere in their record there, and a group of people who aren't. And now you're going to follow them for what? What are you looking for in those two groups?
So you're looking for incident primary open-angle glaucoma diagnoses. One thing to note is that both of these groups have a diagnosis of ocular hypertension. So you're presuming that they've already been seen by an ophthalmologist, and their goal is to continue surveilling them for potential conversion and for medication treatment as well. And so that was the main goal of having them both have a diagnosis of ocular hypertension, to address possible surveillance differences between the groups. And on top of this, we also look at the rates of ophthalmology visits between the groups to ensure that, let's say we do see a protective signal, it's not due to protective effect from them not seeing the ophthalmologist at all. And so we see that there's no difference as well there.
So Ike, what are you telling Jawad to look for then to say this person has moved from ocular hypertension to a diagnosis of glaucoma? What's going to be in the record there from your experience or your knowledge? And how do you guide people looking at these databases to say, there's an event?
Well, this brings up an important point, because these days, a lot of researchers are using big data. And unfortunately, there's a lot of perhaps not best practices with big data. And there's a lot of different things we need to consider. Obviously, this is an obvious one that you mentioned earlier, is that there's just more engagement with ophthalmology. Could there be more eye visits? That's why there's more explanation for a higher diagnosis of conversions. Well, we control for that with ophthalmology visits. Immortal time bias is another concern where patients are misclassified. Well, we did sensitivity analysis to make sure patients were taking it after the diagnosis or multiple visits of taking nicotinamide. So there's a variety of different things to account for. Propensity score matching, very important to look at all the covariates that could confound the conversion to glaucoma and control for them. These are all 3 or 4 different really important aspects of trying to do this. Fortunately, we had a big enough sample to power this. So what we're looking for basically is coding. And we're looking at coding of a diagnosis of POAG or starting medications or doing a laser trabeculoplasty. 3 endpoints we would all agree. that do imply a change in the patient's status from being ocular hypertension to actually being diagnosed with glaucoma. To me, one of the most powerful conversions is somebody who's actually starting therapy, because we start therapy, particularly drops or lasers, when we are absolutely certain someone is actually showing signs of glaucoma. So, and in all three of them, we showed quite marked hazard ratios in support of the protection of conversion to any of those three entities. We also ran sensitivity analysis to include wider range of glaucoma diagnoses to try to have a larger sample, and we found the same thing. So we tried to do as many sensitivity analysis on this cohort, try to pressure test this potential association, I'll call it, and repeatedly we came with the same findings. And that's important because it's often not uncommon to see a spurious finding when you do one type of analysis. And so I want to thank again Jawad for looking at it in this manner.
So let's get to that, Jawad. What were the actual results? What was that hazard ratio? And maybe for a lot of our audience, what's the absolute risk reduction that you actually found in these people that were labeled as being in the nicotinamide supplementation versus the other group?
Yeah, of course. So what we found was that when looking at rates of POAG diagnosis, those who had a history of nicotinamide use had about a 66% reduced risk of being diagnosed with POAG. That's also seen when you look at intraocular pressure lowering therapy, was about 43% reduced risk, and also a 60% reduced risk in laser therapy as well. And this reduced hazard ratio was seen across all of our sensitivity analyses. And when you look at exactly risk reduction, when you look at risk difference, what we see is that among those who were started on nicotinamide, about 3% converted. But when looking at those who were not, it was about 10%. So you can look at around the 6% risk difference between the two groups there as well.
So what do you think of that magnitude? So somewhere between 3 and 10%, let's say 5%, I think you'd have to treat 20 of your ocular hypertensive people for whatever amount of time you decide to have one of them avoid going on a glaucoma. Are there side effects we have to worry about? Is that worth the risk? Will they be compliant with that? What do you think if you were going to then design a clinical trial because you thought it was feasible? Do those numbers make sense to you?
Yeah, great point. I want to mention a couple of things, and you talked about absolute risk reduction. So number needed to treat is about 1 in 18. And I want to make a comparison to the O study. The O study, of course, we know, published many years ago, medical therapy versus non-medical therapy for preventing conversion of ocular hypertension to glaucoma. That study showed a reduction similar to this. In fact, the hazard ratio was a bit higher than what we found even. Their number needed to treat was about 1 in 20. Interestingly enough, by the control group, converted at about 9% or so, which is very similar to what we found in our study. So it kind of validates that actually this is real data. Our controls converted the same amount as it did in the O study. Nevertheless, yes, basically about 1 in 18. And that's a really nuanced question in the sense of what is the right number that's appropriate in terms of balancing risk, balancing cost. Fortunately, cost is not very high with this one, but it's still a society impact as well. And I think we're still trying to address this in glaucoma, right? We tend to overtreat many, undertreat some. And I think as we hopefully get a better targeting in patients, genetics and everything else, we'll be able to have a better individualized approach. But in the meantime, many patients are getting worse, and we are looking for non-IOP lowering mechanisms of treatment. And this seems to be somewhat promising. And you're absolutely right. What we need to do now, the next step is, I don't think the take-home message here is that everybody should be on nicotinamide. The answer is not no. It's not a green light to self-prescribe this. But it does strengthen the rationale for a real good trial. And I think that, randomizing patients in a proper way based on what we found, figuring out the right dosing, which, by the way, we didn't address here. Our EHRs don't differentiate dosing and that type of specific data is what we really need to do. And so I think that's important. Now, as you mentioned, there are risks. Fortunately, most of the risks are not serious, GI related, those type of issues, fatigue, headache. But there's one thing that stands out, which is drug-induced liver injury. And that's seen particularly at higher doses, at 3 grams per day. In the glaucoma trials that have been done, that's about 0.7% of patients that we saw. And in those cases, they did resolve when they're stopping, but that is important for patients and practitioners to understand that aspect if using this drug. Now, lower doses, which many people use, tend to not have this association, but that's what's important. Now, we did match, by the way, based on liver disease for the purpose of this study. So I think a nice RCT done so we can move away from the association, which we found, to looking at causation and figuring out the right optimal dose, figure out the right real world safety in this population. And I hope the study may justify an investment in doing this.
So Jawad, one more question for you. And that is, a lot of times when people find these potential benefits from these sort of investigations, they always wonder, could that just be the healthy cohort gets less glaucoma? The people that are interested in taking nicotinamide or any sort of supplement, are they somehow taking better care of themselves or getting some other confounding factor of their health that's leading to this? How strong can you say from all these careful matching that was done and sensitivity analyses that Ike mentioned, how confident are you that we've eliminated all those? I mean, that's the whole reason, as Ike mentioned, that we have to do a randomized clinical trial about this. Is this as good as you can do and now it's time to do a trial, or are there some other parts that should be controlled for?
Those are particular variables that are difficult to control in a study like this. And what we can do to the best of our ability is to see, in patients who that healthy user bias is more likely to occur. Are they more likely to see the doctor? Are they more likely to see the ophthalmologist? Are they more likely to engage with the healthcare system? One point we're trying to say is, look, their chances of seeing an ophthalmologist after their visit is the same between the two groups. So we're trying to remove that potential argument when looking at the differences in the outcomes. But one point to consider as well is what's running the healthy user bias. Is it patients who are more socioeconomically advantaged? Are they more likely to be able to afford going to the doctor more often? And one point to mention is we did match for differences in socioeconomic and psychosocial circumstances. And what you can see before matching is that actually the nicotinamide group had almost more than twice the percentage of people who could be considered coded for socioeconomic disadvantages. And when you reach the point of where you're being coded for it, you know that it's going to be a more severe position than someone who might just be less likely to afford a medication. And so that's sort of the argument against healthy user bias explaining our results. But, that's always something that there's going to be residual of that we try our best to account for.
So Ike, last question for you. And I'll preface it with something I often think about when we hear about supplements potentially making medical diagnoses better. I think back to a few decades ago when people found an association, not through these methods, but found an association that people who were smokers and had a history of taking beta carotene were less likely to get lung cancer. And so they said, well, let's just test it. And they do a randomized trial to say, is there no difference or does this really prevent lung cancer? And to their horrors, they found in 2 independent clinical trials that were being done around the world, taking the beta carotene actually increased the risk of lung cancer, only by a small amount, but by a confidently definitive amount. So with that as background, what do you tell your patients now who might hear about this? You mentioned a caution even for any glaucoma patients listening to the podcast. What do you tell your patients right now when they say, oh, I see you and your colleagues in California and everyone else are doing some exciting work on nicotinamide. Should I be taking that? Because I don't want to lose vision like I remember my parent did when I used to bring them in. So what do you say?
My answer is always, listen, the most proven therapy for glaucoma and progressive glaucoma is lowering pressure and being compliant with medication, topical medical therapy, lowering pressure, and particularly frequent visits, because that's key to seeing who may need to have escalation in therapy. That is the most proven therapy. I think that nicotinamide needs to be studied more. We need to understand the right dosing. We're not sure about that yet. We also need to understand how it relates to people's genetic phenotype and things like that, and genotype. And we need to understand the risks of the drug, as you mentioned as well. So I think for the vast majority of patients, it's not a green light to start using nicotinamide, number one. Number two, there are some patients, however, that we are stuck. Some patients that are end of the road, we've done a trabeculectomy, their pressures are 10, they're getting worse. And we're looking at either doing another surgery or just observing them getting worse. And those patients, I definitely bring this up. It's an off-label indication, of course. It's a patient's decision based on risk-benefit. And in those patients, I do mention that, along with other therapies as well, that I talk about, even lifestyle therapies that may not be fully proven. I think that's where this really comes into play, mostly in those kind of populations, with a proper educated, informed consent discussion on risk-benefit and monitoring, and then go from there. That's the particularly vulnerable population. We looked at a population where most people didn't convert to glaucoma, number one. And those that did convert, they were early and they could be monitored and treated well. And we know the success of that therapy. So there are going to be some subsets right now, and we are looking forward, and we hope this informs our colleagues and investigators to now look at this in a robust way to see whether there is some causation benefit in preventing glaucoma. And we hope we find something that's going to be useful for our patients. We're excited to see what happens.
I'm excited to hear about it too. So we want to stay informed with what you all learn. So Dr. Muayad, thank you so much for sharing this exciting information with us.
Thank you so much for having me.
And Dr. Ahmed, I cannot thank you enough for joining us as well.
It's been a pleasure. It's an honor to be with you and an honor to be with JAMA Ophthalmology. So thank you so much for having us.
Thank you. I'm Neil Bressler, and we've been speaking on nicotinamide supplementation in primary open-angle glaucoma in patients with ocular hypertension. And you can find a link to this article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.